Good morning, everyone. Welcome to the virtual UCT-Africa platform. I am Dr. Divya Pallavi Ramyead, and today I'll be discussing on allergic fungal rhinosinusitis. A 35-year-old lady presented to our ENT OPD with a unilateral mass in her left nostril for the past 4 months. There was no discharge, headache, epistaxis, facial pain, or anosmia noted. She was RBD positive on heart and was on treatment for hepatitis B. She has no past surgical history. She is unemployed, is a non-smoker, and a non-alcoholic. On examination, a unilateral nasal polyp was seen in the left nostril, and mucin was observed in the left middle meatus. She was noted to have a right septal deviation, a normal nasopharynx, and her ear, oral cavity, and neck examination were normal. We proceeded to do a biopsy where the section showed mucus and interspersed eosinophils, chocolate-laden crystals, and fungal hyphae, which stained positive with pus staining and Gorov stain. There were no malignant cells observed. However, there was not enough representation of mucosa to exclude fungal angioinvasion or lymphoma. We proceeded to do a CT scan. Here, the picture on the left, you can see an axial view of the paranasal sinus where you can see the characteristic double densities. On the right here, you can see a coronal CT scan of paranasal sinus showing the unilateral predominance to the left side. We then proceeded to book up an operation where we did a left middle meatal antrostomy, a left ethmoidectomy, a left sphenoidectomy, and a draft 1 procedure. The findings were that a fungal mucin was observed in all of the left maxillary, ethmoidal, frontal, and sphenoid sinuses. As part of treatment, we started her on fluticasone nasal spray, 2 puffs bilateral nostrils BD, nasal wishing, prednisone at a dose of 0.5 milligrams per kg, iodine drops, and a review was given in 2 weeks with results. Now, before I delve into allergic fungal sinusitis, a brief overview of the classification of fungal sinusitis. Fungal sinusitis can broadly be classified into non-invasive and invasive forms. In the non-invasive form, it can further be divided into non-eosinophilic forms, which includes sinus fungal board and saprophytic fungal infestation. And in the eosinophilic forms, there's allergic fungal sinusitis and non-allergic sinusitis. In the invasive forms, they're further categorized into 3: acute fulminant invasive fungal sinusitis, chronic invasive fungal sinusitis, and granulomatous invasive fungal sinusitis. So how do we define allergic fungal sinusitis? It is an intense, localized allergic or eosinophilic inflammatory process of the sinus disease that results in accumulation of eosinophilic mucin, intense eosinophilic inflammation, and characteristic radiographic findings. In fact, there is a Brent and Kohn diagnostic criteria, which includes 5 major and 6 minor criteria. The 5 major criteria include evidence of type 1 IgE-related hypersensitivity, nasal polyposis, characteristic CT findings, eosinophilic mucus, and a positive fungal smear. In the minor criteria, there's asthma, unilateral predominance, radiographic bone erosion, positive fungal culture, chocolate-laden crystals, and serum eosinophilia. However, for ease, one can proceed to diagnose if they find the presence of chronic rhinosinusitis with nasal polyps and the presence of eosinophilic mucin, as well as the evidence of IgE-mediated allergy to fungus, which is either obtained by skin testing or in vitro IgE immunoassays. Furthermore, if there's no evidence of invasive fungal disease, diabetes mellitus, or immunodeficiency, and the characteristic radiographic findings that I'll be explaining soon, one can diagnose with allergic fungal sinusitis. In fact, there's a new additional criteria that has been contemplated, which is immunocompetence. The reason being, if one observes the classification of fungal sinusitis, one would note that the invasive forms are mostly found in immunocompromised individuals, and as we go to the non-invasive forms, they are observed in immunocompetent individuals. The most common organisms causing allergic fungal sinusitis includes Bipolaris, Cruvularia, Aspergillus, amongst others. And why is this pathology so important? It's because 12 to 47% of CRS patients have fungal rhinosinusitis, and amongst these, 56 to 72% account for allergic fungal rhinosinusitis. One must be cautious as this could represent an upper airway manifestation of allergic bronchopulmonary aspergillosis. The combination of allergic bronchopulmonary aspergillosis and allergic fungal sinusitis represents fungal hypersensitivity in the upper and lower airway, and this forms part of the sinobronchial allergic mucosis syndrome. Therefore, a high index of suspicion is required if a patient comes with a history of asthma and/or rhinitis. What are the risk factors? This includes immunocompetent young adults with allergic rhinitis, asthma, and it is found to be predominant in warm, humid climates and outdoor mold and spores. The pathogenesis, alongside with the host factors and environmental factors, is based on mucosal epithelial barrier disruption. This leads to type 2 adaptive and innate immune response, which leads to a high total fungal and specific serum IgE, and eosinophilic rich mucin and mucus, leading to nasal polyps, mucosal edema, and eventually obstruction. The clinical features include nasal congestion and obstruction, anosmia, postnasal drainage, and failure to improve despite prolonged courses of antibiotics. One must be wary of the warning signs and complications of allergic fungal sinusitis. Bony expansion and bony erosion can occur, leading to extension to extrasinus areas. This includes the orbit, the skin, and brain. In the orbit, one would note and observe double or reduced vision, proptosis, periorbital edema, ophthalmoplegia. In the skin, one would see facial dysmorphism, and in the brain, one would see focal neurological signs, severe headache, meningeal signs, and recurrent epistaxis. In fact, there's a paper published in 2022 of an unusual presentation of extensive allergic fungal sinusitis, where the fungus had in fact invaded into the eye, leading to bilateral proptosis. So on examination, one can note polyposis, predominantly unilateral, and it can be so massive that it is visible at the nasal vestibule. And it is described to, one can observe a thick inspissated mucin, which is described as a peanut butter type, and thick and yellow, brown, or green debris can be seen involving the sinuses. Among investigation, if one has resources, we can opt for immunology, where there's fungal specific IgE, an elevated IgE level will be observed. However, one must note that it is not a screening tool, rather it's used to monitor clinical response. One can also send for fungal culture, where positive fungal culture will support the diagnosis, but a negative culture would not exclude one. The gold standard diagnosis relies on histology and the presence of allergic mucin. So the allergic mucin, in fact, it is described as eosinophilic mucin with necrotic eosinophils, inflammatory cells, chocolate-laden crystals, which are in fact byproducts of eosinophils, and fungal hyphae with stain positive with silver gomeris stains, past stains. We can then order a CT scan, non-contrasted, and these are the 5 characteristic features that one must look out for. Firstly, it is unilateral or there's an asymmetric disease load. Secondly, there's foci of hyperdensities, which can be irregular, speckled, serpentinous, described as double dense, and sometimes a rail track sign. Thirdly, true bone erosion may be present, and one must rule out invasive fungal sinusitis and malignancy. Fourth feature is expansion of soft tissue disease into the orbit or intracranially. And the fifth feature is bony demineralization of the sinus wall, resulting in sinus expansion. So this is a CT scan of the paranasal sinus coronal view, where you can see a unilateral disease load, expansion of the maxillary sinus. And here, the picture on the right is again a coronal view of CT scan, where you can see there is bony erosion, there are areas of double densities, and there's intracranial extension. In fact, there's a CT scoring system based on sinus involvement and location of bony remodeling. If one has resources, one can book an MRI, and the advantage is threefold. It helps to distinguish eosinophilic mucin from other materials that can lead to opacification on a CT scan, which includes infected fluid or trapped secretions in the mucocele. Secondly, it helps to detect subtle or obvious intracranial spread of disease. And thirdly, it's more sensitive in differentiating inflammatory conditions from neoplastic processes. In both T1 and T2 weighted images, one would notice central areas of hyperintensity or signal voids with peripheral enhancement. So this is a CT scan and an MRI scan from a same patient. On the CT scan, you can observe the unilateral load of disease, double densities, bony erosion, and on the T2 weighted MRI, you can see there's a central area of hyperintensity or signal void with surrounding enhancement of the mucosal thickening. So coming to management of allergic fungal sinusitis, the first step is to eliminate fungal antigen, and this is achieved by surgery. And thereafter, we control the recurrence either by immunomodulation, which includes immunotherapy and steroids, or by using antifungal treatment, which is topical or systemic. So as I mentioned, the first line gold standard of care is surgery. We want to remove polyps and allergic mucin, and the advantage is that it helps to restore ventilation and drainage of sinuses. It helps to create a wide sinonasal corridor, thereby allowing for long-term in-office endoscopic examination. It improves access for surveillance and debridement, and it helps with installation of topical meds. There is an endoscopic staging post-surgery classification that is used to track disease. In olden times, there was the Kupferberger staging system, but now there's the Philpott-Java endoscopic mucosal staging system, which defines and establishes detailed description of the sinus cavity involved and the state of mucosa, whether there is no edema, mucosal edema, polypoid edema, or frank polyps. Preoperatively, it is advised to give steroids, as this minimizes intraoperative bleeding and dissolves mucin. One can start the steroids 3 to 5 days prior to surgery, and it is given at a dose of 30 milligrams 3 days prior. The surgical considerations we aim for is, if there is unilateral disease, one should manipulate only on the disease side. Normal anatomy is grossly distorted in allergic fungal sinusitis, and this is due to bony remodeling caused by expansion of fungal debris, and hence caution is advised. Recurrence is highly dependent on the complete clearance of eosinophilic mucin. Post-operatively, systemic glucocorticosteroids are given at a dose of 0.5 milligrams per kg and is tapered over a few weeks. The duration can be 1 to 3 months. Topical intranasal glucocorticoids are initiated as soon as possible and is to be continued for at least until the next few years. Other medications that can be given is antifungal. However, this is found to be more effective in recalcitrant disease and is used as a void-sparing agent. The reason being is antifungals have adverse effects, which include, for example, in itraconazole, elevated liver enzymes, and there are no randomized controlled trials that really advocate for antifungals. Immunotherapy can also be given, and it has been found that omalizumab, which is an anti-IgE, is a useful adjuvant in severe atopic asthma, allergic rhinitis, and in chronic rhinosinusitis with nasal polyps. Hanukkah honey is also used in patients who are refractory to surgery. As I mentioned, there is no consensus guidelines to advocate for systemic antifungals, as amphotericin B, triazoles, and caspofungins have adverse effects. It is a paper that shows how patients who were treated with surgery and steroid, so here there were 33 patients with steroids, only 5 of them had recurrence, while in the group with surgery and placebo, 15 out of 30 recurred. Nowadays, there are studies that are ongoing regarding the role and expectation of biologics. This includes omalizumab, dupilumab, and mepolizumab. And the reason why biologics is being studied upon is because allergic fungal rhinosinusitis and chronic rhinosinusitis with nasal polyps share the same immunologic profile. Just a little note on pediatric allergic fungal sinusitis. In kids, fungus has a more aggressive nature, has a high serum immunoglobulin E, and has more frequent bony erosion and malformations, and hence one must act promptly. A note on future therapeutic options, which are actually under study, includes blue light therapy, polyoxama 407 gel, providone iodine, and nitric oxide releasing solution. Some differential diagnosis one must exclude includes allergic rhinitis with fungal allergy. In this circumstance, one would not observe symptoms of chronic rhinosinusitis. Another differential could be chronic rhinosinusitis with fungal allergy, where here there will be absence of eosinophilic mucin containing fungal hyphae, and a CT scan of bilateral disease. A fungal boil could also be a diagnosis to exclude, and here one would see the disease limited to a single sinus. In acute and chronic invasive fungal sinusitis, one would note fungal hyphae and homogeneous attenuation on CT scan. But more importantly, this is most commonly seen in diabetics or immunocompromised hosts. And finally, there's also a pathology termed eosinophilic mucin rhinosinusitis, where there is eosinophilic mucin but no detectable fungi, no type 1 allergy, and it is more commonly bilateral with hyperdensities on CT scan. So to conclude, this is a nice flowchart which shows that when one sees a patient with atopy and was suspecting chronic rhinosinusitis with nasal polyps, there's failure to respond to antibiotics, one can book a CT scan and thereafter take a biopsy, send for fungal culture. If there are ophthalmic and brain signs, refer to the appropriate team and proceed to do an endoscopic sinus surgery with the aim of debulking and removing the fungal load and mucin, and thereafter start on steroids, and if ever they are recalcitrant, then consider for antifungal or immunotherapy. These are my references. Thank you for your attention. Are there any questions?
Yeah, actually, no question. This is very nice presentation. Just to emphasize that CT scan is the mainstay of diagnostic modality we use to diagnose fungal. Whereas in MRI, it's not really clear. Sometimes when you look at the MRI, you might have to think of other things like lymphomas, etc. So CT scan is most important diagnostic tool for imaging, as well as surgery to clear the fungal mucin right. The best way to deal with this. Otherwise, systemic antifungals with presence of fungal mucin is not really useful.
Are there any more questions? Okay, thank you for your kind attention. A reminder, Friday is a public holiday in South Africa, so we'll have our next meeting on Wednesday next. Thank you.